I'll be talking about a new iron molecule. Before I begin with, we all know that in pregnancy, amongst all the anemias, iron deficiency anemia is the most common, number one. Number two, there are countless iron tablets in the market. There is ferrous salts, ascorbates, gluconates, ferric pyrophosphates, there are carbonyl iron, iron polymaltose, complex irons. Yet, every year, some or the other new molecule keeps coming, but there are patients who cannot tolerate oral iron during pregnancy because of the severe GI side effects. And that is why the reason that this innovation is continuing. Third, we all know that iron is absorbed not in the stomach but in the duodenum and jejunum, and it is absorbed in the ferrous form. So before I begin with the particular molecule, just some observations. Let's take it as fixed that anything less than 12 hemoglobin is considered as iron deficiency anemia. It is only when we work with this ferocity that we will be able to make our country anemia mukt. Now, this is something which when I looked at this particular slide, I understood that why ma'am is so passionate about the Kerala model. Look at the entire country. It is only Kerala and 2 states in the Far East, Nagaland and Manipur, which have a pink color, which indicates mild public health problems. Rest of the country is either dark red or red, which indicates severe to moderate public health problems, which is so sad. Despite so much of effort being done by the public and private sector, still you see the entire country is anemic. So keep it in mind, anything less than 12 is anemia. Let's not go on severe, moderate, mild. 12 se kam hai to anemia hai. Now, iron deficiency symptoms are so vague. They are so vague that one doesn't come to a conclusion or come to a diagnosis right away. Complaints like weakness, shortness of breath, fatigue, poor focus, headaches, they all affect the quality of life. They impact the daily activities, the productivity, and they also aggravate the underlying additional illnesses. That is why it is so important to treat iron deficiency anemia both in the pregnant and non-pregnant individuals. The wide-ranging effects of iron deficiency reflect the crucial role that iron plays in oxygen transport, enzymatic reactions, cellular processes, immunity, and cognitive functions. We know very well how to manage iron deficiency anemia. It could be non-pharmacological methods by a rich diet, or pharmacological oral iron therapy, parenteral, and then of course, if nothing else works, we have blood transfusion. I've already mentioned that absorption of iron occurs in the duodenum and proximal jejunum, and it is at physiological pH, iron exists in the oxidized ferric form. To be absorbed, it must be converted into the ferrous form, or it is bound by proteins such as heme. On the left side of the slide is how it is absorbed by the duodenal enterocytes. There is this enzyme by the name of DMT which imports iron across the apical surface. Then another enzyme which exports iron across the surface. Then hepcidin, increased by iron loading or inflammation, impairs cellular iron export. To make this all little more clear as to how iron is absorbed, both the heme and the non-heme part, and why the problems occurs. So here iron is absorbed in the body in the form of heme or non-heme. Heme is transported into the duodenum enterocytes via a heme carrier protein. Then onwards, it forms a part of the iron pool. This is the heme part. Make it very simple. So it is absorbed in the iron pool within the enterocyte cytoplasm. Then we have the non-heme iron, which must be in the ferrous state before it enters the enterocyte lumen. So there is another enzyme which helps reduce Fe3 into Fe2. And then again, the same divalent metal transporter transports it, and that also becomes a part of the labile iron pool. From here, it can either bind to ferritin for storage or transported out of the enterocyte via another 2 enzymes, and then it is converted into the ferric state, then binds to transferrin, and it is then transported all around the body. To make it more simple, now iron is regulated at the level of intestinal absorption to prevent overload. Because we keep giving iron, we don't monitor the serum ferritin levels. So it is like, inbuilt in us. 14 weeks onwards, because we are aware of the physiological anemia of pregnancy, we put the patient on iron tablets. Now, is there an iron overload? Yes, there is. Now, to prevent iron overload, because there is no specific iron excretory pathway. So what happens? Hepcidin is the main regulator for the accumulation of iron in the body, which is secreted by the liver. When the iron stores and circulating iron in transferrin are at saturation point, liver hepatocytes start producing hepcidin. This triggers the degradation of ferroportin. This is where the iron had got attached to the enzyme, and further iron absorption is stopped. So there is no further buildup. Now what happens in a regular method? We have a ferrous salt. It is bound to a negatively charged anion such as a sulfate, fumarate or a gluconate to form the ferrous iron salt. For absorption, ferrous iron must dissociate itself from the salt. And this dissociation occurs in the stomach. So what happens is that the free iron radicals, they start clumping and they start irritating and damaging the lining of the stomach. And the dissociated ferrous iron then reacts with the hydrogen peroxide in GI tract, forms reactive oxygen species, which is toxic and damage lining of the GI tract. And this is where the GI side effects start occurring, and there is a huge non-compliance. So, a preferred iron would be, which is excellent absorption, high bioavailability, fastest HB rise, of course, good GI tolerance. That is the main purpose, and good patient compliance. If there is no GI side effects, compliance will be good, no interaction with food, because you have to be very specific as to what she's eating and how she takes. So there is a gap, the need gap. We need an iron, oral iron, which is easy to use, good absorption, which has low risk of GI side effects, and there is low iron dumping. So we have this new molecule, ferric maltol. It has been approved by the FDA. And a lot of studies, I looked up the net and there were multiple studies regarding this particular salt, especially in patients with inflammatory bowel disease, chronic kidney diseases, and pulmonary hypertension, where there is chronic anemia always. Now this iron maltol complex is stable at a physiological pH. So what is the unique mechanism of ferric maltol and why they claim it to be better? Ferric iron is tightly bound to 3 maltol molecules. Now these maltol remains tightly bound as it passes through the stomach. So here the iron dumping does not occur because there is no dissociation. So there is no formation of ROS. This complex then dissociates only after it has been absorbed. Absorbed iron is then transferred to transferrin and ferritin. So there is no irritant in the stomach. Further explanation is this. Ferric maltol complex remains intact in the intestinal lumen before absorption via iron transporter mechanism, minimizes the risk of GI toxicity due to production of free radicals from free iron. Iron uptake with ferric maltol is saturable. It avoids the potential for iron overload. Ferric maltol complex dissociated by iron transporter mechanism. Maltol is rapidly absorbed by diffusion, eliminated in urine as glucuronide. So there is no accumulation of maltol. Unabsorbed ferric maltol is excreted intact in the feces. So all in all, there is no dissociation in the stomach, no irritation of the gastric lining, and there is no overloading. It is excreted as it is. So it is only oral iron, ferric iron, which is bound or chelated to maltol. It is a lipophilic iron chelator complex, increases the transfer of iron across cell membranes and across the GI tract, increasing iron absorption. First, ferric iron formulation. Degree of iron absorption is equivalent to the ferrous iron salts, and when it is taken on an empty stomach, surprisingly, the absorption increases 5-fold compared to when it is taken with food. So you tell the patient to take either an hour before or 2 hours after she's had her meals. The network meta-analysis indicated favorable hemoglobin improvement with ferric maltol, which is approximately 2.7 grams versus the placebo at 12 weeks. And after 42 weeks of treatment, it was found that the hemoglobin rise was comparable to the intravenous ferric carboxymaltose in patients with IBD. And the unabsorbed iron remains chelated in the iron maltol complex. It is excreted into the feces, thereby potentially reducing the risk of intestinal damage from the free iron. So what is the indication? Of course, for iron deficiency anemia, it is an alternative to IV iron for patients who cannot tolerate salt-based oral iron therapies. 1 to 2 tablets daily, as I just said, 1 hour before or 2 hours after, and the duration can be given safely up to 12 weeks. or until the ferritin levels are within the normal range. What is the clinical evidence? I looked up, and here it was found that comparison was done in patients with inflammatory bowel disease, chronic kidney disease, and what was found? That when compared oral ferric maltol versus intravenous ferric carboxymaltose, both achieved clinically meaningful increase in hemoglobin after 12 weeks, and the levels were 2.5 versus 3, which is fairly equally comparable. Though the iron uptake was slower with initially slower than the IV iron replacement, I'm talking about the oral complex, and the iron storage measures were increased and sustained over time, even up to 52 weeks to clinically meaningful levels. So what is the conclusion? Ferric maltol is associated with statistically significant and sustained increase in hemoglobin and iron indices in patients with the iron deficiency and CKD. It is well tolerated even up to a period of 52 weeks. As far as safety profile is concerned, when over the 52 weeks, it was found that the percentage of patients who discontinued barely rose beyond 8%. So the summary is, it is stable, remains strongly chelated until the point of absorption. The unabsorbed iron remains chelated and excreted in the feces, so the GI toxicity is minimal. Optimum iron absorption with minimal toxicity, indicating favorable hemoglobin improvement, 2.7 grams versus placebo at 12 weeks. Thank you.